Good evening, everyone. Welcome to First Aid AMC Clinical free 2-week session again. I hope you guys are enjoying our free session so far. So you know that First Aid always offers these 2-week sessions for you to understand the course, for you to learn about AMC Clinical, and most importantly, understand the way that we take our classes. So you are having back-to-back classes. I understand sometimes it can be quite tricky, but that's how the course is designed because there are a lot of things to discuss. And ideally, even this is a 5 months course, it's still sometimes we struggle to finish everything. It's just because there are a lot. So think about some course if they are just saying that they can finish your clinical preparation in 6 weeks, 8 weeks. Most of the time they can't finish all the important topics for the exam. So you just get to understand AMC Clinical, but that will not be enough to pass your exam. So I do not believe that a 6 weeks or 8 weeks course can finish AMC Clinical preparation, even if they're taking more than 3 classes in a week. Like we're taking 3 classes in a week, sometimes even 4, but it's still we struggle because we try to finish everything that's needed. And when our students go for the exam, they are very confident. They know that yes, I know most of the cases. I know each and everything about AMC Clinical. So their confidence is sky high in comparison to any students from any other course. So that's what you are learning from here. This 2-week session is going to give you that understanding that how much we are covering just in 2 weeks. And throughout these 5 months, there will be more and more important informations, more and more important clusters and cases we are going to discuss with you. Now, tonight class is going to be one of the most important class for your AMC clinical preparation. So we are going to cover cardiology, and from cardiology, we are going to cover the most important cluster of cardiology, which is chest pain. Now, to understand medicine topics, because this is your first class on medicine, we are going to go through it step by step. I'm going to show you the structure first, how to dissect all the tasks in the exam, and then we move on into our cluster. Remember, now you know how we take our theory sessions and how we take our role play sessions. And I'm sure you enjoyed Dr. Cynthia's last class, which was the role play sessions on random cages. It must be exciting. And the theory classes, already you have understood the psychiatry we did a little bit. Today, it's all about medicine and how to start your medicine preparation. It will start from cardiology. So first of all, if you guys have any questions throughout the class, feel free to ask in the chat box. I always keep the chat box open and I'll try my best to answer your queries. Now, first of all, before we start cardiology, I want to show you how you are going to build a structure for medicine-related cases. For every cluster or for every subject, there are different structures that we follow. And these structures are the vital pillars of your exam preparation. Because many times you don't need to even memorize anything. All you need is the structure. Because eventually, when you start doing role play, you will know every questions. You will know what to ask. So these structures are going to be the first thing that you need to learn. So you have noticed that in AMC clinical exam, the cases comes as, let's say we're talking about history cases or theory cases, not physical exam cases. Theory cases comes like they give you a stem, like let's say 50-year-old patient coming to us with a sudden onset chest pain. The task will be taking a history from the patient, then asking for physical examination, finding from examiner, And then sometimes it could be investigations, diagnosis, management. So tasks can be multiple. Now, almost every history cases or almost every theory cases, there will be history as a task. Some will not have any history in the task, but most of them will have. So when we have history, how we start this case? So first of all, in a history task, you greet with the patient politely. You introduce yourself, who you are. So let's say, hi, this is Dr. Arshan. I'm one of the GP in this clinic. So nice and easy, nice and short, but direct. So hi, this is Dr. Arshan. I'm one of the GP in this clinic. Hi, this is Dr. Arshan. I'm one of the junior doctor in this emergency department. So, and then nice to meet you. Okay, so greet politely, introduce yourself, and tell your position in this GP clinic or in this hospital. Hi, this is Dr. Arshan. I'm one of the junior doctor in this emergency department. It's very nice to meet you. I understand from the note that you are having chest pain. Sarah, chest pain can be very scary sometimes, but now that you are here, I'm going to try my best to manage your condition, and we will go with this. Or Sarah, I understand the chest pain can be very scary, but please don't get scared because you are here with us. You are in safe hand, and I'll do everything possible to manage your condition. So once we greet and we do the introduction, the next thing is have a look at this stem, that what is the main complaint for this history, chest pain. So reassure the patient that you are here and I'm going to do everything possible to make sure you get better. So that reassurance helps a lot for a patient who is seeing you. Okay? After that, if it is an acute case, like someone having acute abdominal pain, acute headache, someone who is having motor vehicle accident, something which is acute, we always make sure from the examiner whether the patient is hemodynamically stable. By hemodynamic stable, we means how is the patient's blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. So how do we do it? So let's say we reassure the patient. So Sarah, I understand from the note that you are having a chest pain. It can be very scary, but now that you are here, I'm going to take care of you and I'll do everything possible to manage your condition. Sarah, because you are having chest pain, I would like to talk to my examiner first and come back to you. So this is how we do it. So if it is an acute case, before asking any further history, we need to make sure our patient is hemodynamically stable. So you take excuse from the patient. Sarah, please excuse me for a moment. I'll talk to my examiner and come back to you. Then in face-to-face exam, you turn over. So if you are sitting on a chair, examiner usually will be standing behind you. So you just turn around towards the examiner and say, dear examiner, I would like to know if my patient vitally stable for further history. So, dear examiner, I would like to know if my patient vitally stable for further history. Now, two things can happen. Examiner can say, please proceed. So they can say, please proceed, or please stick to your task. So stick to your task means that examiner doesn't want to say whether the patient is stable or not. Please proceed doesn't mean anything. It's also the same that I don't want to give you the vital now. Third response can be, yes, your patient is stable, move on. Fourth could be that, what do you mean? What do you want to know? So examiners sometimes can ask that, what do you mean? What do you want to know? In that particular case, you ask specifically from the examiner, what do you want to know? So, examiner, I would like to know my patient's blood pressure and pulse rate. So in exam, you can only ask 2 to 3 things together to an examiner. You can't say, dear examiner, I would like to know blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. That's not how it should be. So you can ask like this, examiner, I would like to know about my patient's blood pressure and pulse rate. Then examiner will say blood pressure is 130/80, pulse is 70. How about respiratory rate, temperature, and oxygen saturation? Then examiner can give you those information. Okay. Now that you know that patient is vitally stable, you come back to the patient. So you turn around to the patient. So, Sarah, thank you so much for waiting. Now, Sarah, would you please tell me a little bit more about this chest pain? So our next step is HOPC, which is the chest pain in here. Now, because it is a chest pain, we will also offer painkiller initially to this patient. Okay? So any kind of pain, if there is headache, abdominal pain, chest pain, any pain, we always offer painkiller to the patient initially. So either you can give the painkiller after reassuring the patient before you go to the examiner for vitals, or you can also offer the painkiller after you come back from the examiner that, Sarah, thank you so much for waiting. Sarah, I know you are having chest pain. Would you please tell me how bad is the pain in a scale of 1 to 10? Sarah said, Doc, it's 8/10. I'm so sorry to know that, Sarah. I'm going to offer you some strong painkiller, but do you have any allergies? No, doctor. Okay, I'm going to give you painkiller so you'll feel comfortable after that. Now, for a chest pain, the painkiller that we offer is IV morphine or IV fentanyl. If it is something else like abdominal pain, headache, then the painkiller that we will offer is just simple paracetamol. So based on the pain, we offer different kind of painkiller. Should we say the name of the painkiller? Not a bad idea. We can say that. So again, examiner mentioned that patient is vitally stable. We came back to the patient. So Sarah, I understand that you are having chest pain. How bad is the pain in a scale of 1 to 10? Doc, 8/10. I'm so sorry to know that. I'm going to give you some strong painkiller like IV morphine, but do you have any allergies to painkiller? No, doctor. All right, so I'm going to arrange that for you. So that's it. You don't need to say that I'm going to ask the nurse to give it to you, or you don't need to pretend that you're talking to a nurse so that the nurse can give it to you. So it's not needed. You just say that you are going to arrange a painkiller. That's it. After that, you ask the patient, now, Sarah, would you tell me in detail that, can you please tell me a little bit more about this chest pain? So then always important that your HOPC, which is history of presenting complaint, in here, let's say it is chest pain, we need to always start with an open-ended question. So open-ended question means that, Sarah, would you please tell me a little bit more about your chest pain? So whatever information this role player is supposed to give you, when you ask that open-ended question, you will get those information, which is vital part of this case. So whatever you don't find out from the role player, or whatever it's not given in the STEM, those things you will now ask one by one as a closed-ended question. Like in the STEM, already mentioned that patient started to get the chest pain 30 minutes ago. Do we need to ask again to the patient that when did your pain started? No need. So if something is already given on the STEM, if already on the STEM they say that patient is vitally stable, do we need to go to the examiner and ask for vital? No need. So you always play smart in the exam. If something is already given, there is no point of asking it again. You are just wasting your time. If role player when you asked about that open-ended question, can you tell me more about the chest pain? Role player just said that, yes, doc, I started to get the pain just half an hour ago, and I was just running, or I was just having some exercise, or I'm just walking on the street. Now, your first question is, when did it start? What were you doing at that time? Now, it means that you did not listen to the patient, or you are way out of your mind. And these things are not taken too good in the exam. And it shows to the examiner that you are not understanding what this role player is saying to you, or you are not even listening to the patient. So it's very important, and this is the number one important thing in history, that if something is given by the patient, you don't ask it again. Whatever left, you just ask it. So your HOPC should be in detail. After that, you go to the differential diagnosis, as many as possible. Finish with SADMA, which is smoking, alcohol, drugs, medication, allergies. So we don't ask all of them, but we ask about smoking, alcohol, and medication. These three we normally ask to every patient. And then finish with past medical history and relevant family history. That is the format for any history that we are going to do. So greet and introduction, reassure the patient, hemodynamic stability, HOPC in detail, offer painkiller when the patient's main complaint is the pain, differential, SADMA, past medical history, family history. Make sense to everyone? No need to mention the dose of the medication for clinical exam. Just the name will be fine. So now that you know about the history format, the next task will be physical examination from examiner. So you must have done that with Dr. Cynthia as well. So physical examination from examiner is a common task in face-to-face exam. So after taking the history, your task will be ask physical examination finding from examiner, and whatever you ask, that will be given to you by the examiner. If you don't ask something, that will not be given. So when we ask physical examination from examiner, so after the history, you thank the patient that thank you, Sarah, for all the information. Now I'm going to my examiner and I'll come back to you. Then you turn around to the examiner and say, dear examiner, I would like to know physical examination of my patient. Or dear examiner, I would like to do physical examination on my patient. On general appearance, is my patient comfortable or in distress? So that's for medicine, we always ask this. Is my patient comfortable or in distress? How about the vitals? Now, if examiner initially said all the vitals, then we don't need to ask it anymore. If examiner did not say about the vitals, then you ask it here. So how about the vitals? Blood pressure and pulse, please. And then ask about respiratory rate, temperature, and oxygen saturation. BMI, not always we need to ask it, but for cardiovascular case, we ask the BMI as well. Then we have pickled. Pickled include all the general examination that we do. So pickled has pallor, icterus, cyanosis, clubbing. So this C is actually K. So pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, and dehydration. Now, do we need to ask all of this? No. It's always relevant. For a chest pain, which one is relevant? For chest pain patient, pallor anemia can come as angina, so that can be relevant. Edema is very important. So these two will be more relevant than any others. Okay, so only the relevant one you will be asking. After the pickled, we go to the main systemic exam. So for a chest pain, what is the main system? Cardiovascular. So you will need to ask the cardiovascular system in detail, which means inspection, palpation, auscultation, all of them. And then quickly we do other relevant system. What else is relevant for cardiovascular? Respiratory system, right? That will be quick one. Now, again, these are format. We will discuss them in detail. And lastly, we finish with office test. So what are the office tests? Office tests are those tests which you can do in the bedside. So bedside test we have, definitely ECG is important in here. Blood sugar level. Sometimes we can do urine dipstick. We can do urine pregnancy test. Now it has to be relevant. So these are the commonest office tests that we can do for exam. So at the end of physical examination, we can ask for this office test from examiner. And these are important, so we can always ask about these relevant ones. Okay? Now, how to ask all of this, you will know just in a very short time. So this is going to be our format for physical examination from examiner. General appearance, vitals and BMI, pickled, main systemic exam, relevant system, and then office test. For a chest pain, is neurological exam relevant? Is musculoskeletal system that relevant? Is abdominal exam that relevant? No. We can say that musculoskeletal chest pain, yes, we can do it only if your history suggests that. Otherwise, these systems are not that relevant. So you don't bother about it. You don't need to even ask for this. So the main system should be asked in detail, and then any relevant system, you can ask it quickly. I will show you how to do this quickly. Once you get the finding from examiner, you thank the examiner and you come back to the patient for explaining the diagnosis. When we explain a diagnosis, this is the format that we use. So first we say what is the diagnosis. Then we explain the diagnosis and say why you have got it. That means we try to talk about the pathophysiology. Like if it is a myocardial infarction, then we say that you have got your coronary artery or the blood pipe that supply your heart has got blocked. So you explain the diagnosis and give the cause. Explain the clinical features. And is it a common or uncommon condition? And then at the same time, we reassure the patient. And sometimes we talk about the complication that left untreated, it can be life-threatening. That's complications. Now, again, this can be quite tricky for you, but when we do a case, you will understand how we're doing it. So we give the diagnosis first, explain the diagnosis with the cause, give the clinical feature. Is it common, uncommon condition, and what could be the complication if we don't treat it? After explaining the diagnosis, most of the case, we will go for differential diagnosis. Now, definitely, if it is a task, then DD is must. But sometimes even differential diagnosis, even if it is not in the task, it is always a good idea to give some differential in the exam. Then, if it is a management task, we need to decide whether we can treat this patient in the GP clinic or we need to send this patient to the emergency. If patient is already in emergency, then we decide whether we need to admit this patient or we can discharge the patient. After that, if you need to admit, you admit. Once you admit the patient, two things we always do. We call our senior because we are a junior doctor in this exam. Do not think that you are going to treat this whole thing by yourself. Okay? This is the one of the most important cause of failing the exam, because you think that you can manage a acute ST elevated MI by yourself. But you're not supposed to do that as a junior doctor. As a junior doctor, your job is to take a proper history, find out the diagnosis, and then as part of the management, you talk to your senior. So you call your senior and also involve a cardiologist, right? And then in the meantime, you are going to arrange the necessary relevant investigation. And then we talk about the further management. So this is how we are going to explain a particular diagnosis, differential diagnosis, and management in the exam. So this will be the format in your head. When you explain something, you explain the diagnosis, give the cause, what is the feature of this condition? Is it a common, uncommon? What can be the complication if we don't treat the patient? What are we going to do? Are we going to admit this patient, or are we going to just discharge the patient? What will be the investigation and what will be the treatment? Okay. So this will take time to understand. Eventually, when we do a lot of case, you will gradually understand them. Now let's move on to the chest pain cluster. And this format, we are going to build the cluster on the basis of this format that you have just learned. The theory classes are like this. We're going to give you cluster, and under one cluster, we are going to do a lot of case together. Okay? Like in the chest pain cluster, because this requires a lot of discussion, we might not be able to do a lot of case today, but the cases that we are going to do, it's super important for exam. With cluster-wise approach, you learn one particular history and physical examination format, and based on that, you can do 5 to 10 cases. You don't need to remember the history. You don't need to remember physical examination. All you do is remember the format. And you will see how we can shorten your exam preparation based on this cluster-wise approach. Okay. Now we will discuss about these things, Ella, that how to do the differential diagnosis. You will understand all of this once you start a particular cluster. So let's move on with the cluster, and then all of these questions that you guys are having, it will be dealt with. So when we find a patient with chest pain, what are the differential diagnoses that we need to remember? Remember one thing, guys, that there is nothing important than remembering differential diagnosis in this exam. How much differential diagnosis you are asking, that sometimes give you the pass mark in your history. Without a good differential diagnosis, your history will never be a pass mark. Okay, so try to remember as many as differentials as you can. There is no specific number of it. So in the 2-minute outside, when you are getting a stem, the first thing you remember is what are the differential diagnoses for this case. So for a chest pain, it could be cardiovascular, could be respiratory, could be gastrointestinal, musculoskeletal, neurological, could be psychological. So cardiovascular is the most important one. Could be a stable or unstable angina, could be myocardial infarction, it could be acute pericarditis, could be aortic dissection, could be aortic stenosis. Then we have respiratory causes such as pneumonia, pulmonary embolism, pneumothorax. In the GIT, we have reflux, peptic ulcer disease, esophageal rupture, esophageal spasm. Musculoskeletal are important, so could be costochondritis, could be a rib fracture, even sometimes muscle strain can come as chest pain. Like a patient just went for a heavy gym. After 20 years, he went to the gym and started lifting a lot of heavy things, So definitely this patient will come to you with a muscle strain, right? So that's commonly found in our real life. Neurological disc prolapse, especially thoracic disc prolapse, can come as a referred pain to the chest. Herpes zoster. It's very important that I believe there is a case where it came as a chest pain, and at the end we found that there is a shingles case. So that is an exam case also. So quite tricky, right? So if you don't remember this differential, you can easily miss this. And then always anxiety related. So psychological cause should be asked. So panic attack, anxiety attack always can come as a chest pain. Now, one by one, let's differentiate all of them because that's how we know. So first of all, if we discuss about this in a nutshell, that what we normally look for when we actually ask this history. So first of all, if it is a stable angina, the chest pain, which is cardiac chest pain, it is usually left-sided chest pain, and the pain will be felt as tightness, heaviness, or they can say something is constricting my chest. Someone is sitting on my chest. So tightness, constricting, heavy feeling in the left side of the chest, and the pain radiating to the neck, jaw, right or left arm. Most commonly it goes to the left arm, but some of the cardiac pain can refer to the right arm as well. So don't just rule out cardiac chest pain if there is a referred pain on the right arm. This is a common mistake. And then it can also go to the back. Associated with nausea, vomiting, excessive sweating. Now remember, angina pain will be short lasting. The pain will be less than 10 minutes, which is a stable angina, and pain will only come with exertion. That means patient is walking, doing some exertional work, and that time patient got the pain. And when they took rest, the pain went away. Whereas myocardial infarction pain, the pain will be same. So acute, severe left-sided chest pain felt as tightness, constricting heaviness, radiating to left arm, neck, jaw, or right arm, associated with nausea, vomiting, sweating, shortness of breath, but it is lasting usually at least for more than 20 minutes. And the pain will not get better with rest or even with nitroglycerin sometimes. Okay? So that's how we know that is it a myocardial infarction pain. How about pericarditis pain? Pericarditis pain comes as an acute, sharp, stabbing chest pain. The pains can be central or left-sided. The pain has a specific characteristic. It is called pleuritic chest pain. That means the pain will get worse with deep breathing or giving a cough. Pain gets better when they lean forward and get worse when they lie flat. And many times, pericarditis pain, there will be a preceding acute viral illness. So 1 week ago, patient got a flu-like symptoms, and after that, patient came to you with this kind of pain. How about aortic dissection? Aortic dissection comes as sudden onset of severe central chest pain, and the chest pain is kind of tearing or excruciating pain. So it's a very severe chest pain, and the pain radiates to the back. How about aortic stenosis? Aortic stenosis comes as a intermittent chest pain, especially with exertion. Plus, they get shortness of breath on exertion, and they get this syncopal attack, which means they get blackout or sometimes dizziness. So this is a triad of aortic stenosis: chest pain, shortness of breath on exertion, and syncopal attack. Okay, so these are our cardiovascular causes. Pneumonia, we know that there always will be a fever, they will have cough, they will have shortness of breath. Pulmonary embolism comes as pleuritic chest pain. So the pain will get worse with inspiration or deep breath. There will always be a risk factor like long travel history. They might have previous clotting history, maybe a family history of thromboembolism. So some kind of risk factor will be there. Along with the chest pain, these patients also get shortness of breath and palpitation. Pneumothorax can happen just without any cause. It can also happen after a trauma. But most of the time, they might give you a history that patient had an injury to the chest recently. All of the respiratory causes of chest pain are pleuritic chest pain. So when you get a pleuritic chest pain, think about either it is pericarditis or it is a respiratory cause. So that's why asking about the nature of the chest pain gives us a very important clue that where we should look into. Then we know about reflux. So gastroesophageal reflux, peptic ulcer disease, usually the pain will be associated with something like in some food, especially hot, spicy food. Musculoskeletal, rib fracture, patient will always come to you with a trauma to the chest, maybe had a fall and then ended up fracturing the rib. Costochondritis is the only chest pain where patient will say that when I touch my chest, it is very sore to touch. So this is the only chest pain which will be tender. Neurological, if it is herpes zoster, there will be definitely the shingles rash. An anxiety attack, if we can't find out anything from the history, then we go to the psychological question. And then we might find out patient is quite anxious. Okay, so this is what you think in your head. In your head, you need this information to get the diagnosis. Now you can ask me, is all of these important for exam? So the important ones for exam is myocardial infarction is the super important. Pericarditis is important. I haven't seen aortic dissection coming in exam, but yes, we should know it. Aortic stenosis is also a handbook case. Now, respiratory causes, all of these are important, but it comes under respiratory cluster. Reflux comes as a chest pain. I have seen cases like that. Peptic ulcer, I haven't seen, but again, if reflux can come, peptic ulcer can come in exam. I haven't seen these ones, but these are very common. So you should always ask this. Okay. Shingles come in exam and anxiety or panic attack comes in exam. So you can understand the importance of this cluster. So many cases comes from a single cluster. So I have kept some of the history taking in here. These are from John Mota, that what a chest pain of acute coronary syndrome should look like. That's what I said, that left arm pain is common, but bilateral or right arm pain are more specific. An acute coronary syndrome may be associated with shortness of breath, nausea, and sweating that we know. Let's go on to the history. So how we are going to take a history of chest pain. This is important to understand. A lot of cardiology cluster, a lot of medicine cluster will depend on how you learn today's history. So first of all, let's say our patient name is Jack. So how we are going to start these chest pain questions. So we'll say, hi Jack, I'm Dr. Arshan. It's very nice to meet you. I'm one of the junior doctors in this hospital. How are you feeling now? So patient will say, Doc, I just have this chest pain. So you'll say, Jack, I understand chest pain can be very scary, but I'm here with you and I'll do everything possible to manage your condition. But before I ask any questions, I need to make sure that you are vitally stable. So please excuse me for a moment. I'll come back. after talking to my examiner. Then go to the examiner and say, "Dear examiner, I would like to know if my patient vitally stable for further history." Examiner says, "Please proceed." "Thank you, examiner. Well, Jack, thanks for waiting. So Jack, can you describe how severe your pain in a scale of 1 to 10? Doc, it's 7 by 10. Well, it must be very painful. So Jack, do you have any allergies to any medication? No. Well, I'm going to arrange a strong painkiller for you. Hopefully, you will feel comfortable after that." Now, why I didn't mention the specific name of the painkiller here? Because I don't know what is the cause of this chest pain yet. So that is important. Case by case, we can change this approach. There are cases in the exam where in the STEM, they already give you a ECG of ST elevated MI. If we already know from the STEM that it is a ST elevated MI, then we can say that yes, we are going to start a strong painkiller for you, such as IV morphine. Hopefully, you will feel comfortable after that. That's relevant to say. But if we don't know, there is nothing else written, just patient came to us with a sudden onset chest pain. In that case, it is not relevant to start IV morphine for everyone. Chest pain can be due to a lot of other causes. So in that case, you just use a vague painkiller. That's it. You don't say the name, you don't use any other things. All right? And this is all right. As long as you are saying that you are going to arrange a painkiller, that's all right. Although it is vague, but you are not sure. Now, if the patient asks you that what painkiller, you will only say, "I'm going to arrange just a paracetamol for you for now until I know what's causing your pain." In that case, you don't say, "I'm going to arrange a strong painkiller." You'll just say, "I'm going to arrange a painkiller for you. Hopefully, you will feel comfortable." Does it make sense, guys? Do you understand that how you have to be smarter in the exam? Because if you don't know the cause of the chest pain, for every chest pain, we are not going to start morphine straight away. Okay, now that we offered the painkiller, the next is HOPC. So you will ask the patient that, "Well, can you please tell me a little bit more about your chest pain?" So patient will give you some information. Based on the STEM and the patient information, whatever you couldn't find out, you will ask from here. Any pain question, we follow the Socrates question. You know about the Socrates or Short-Sara questionnaires. That's what we're going to ask. So the pain questions, we follow the Socrates model. So S for site, so where exactly is the pain? O for onset, when did it start? Or what were you doing when the pain started? Characteristic, how does the pain feel like? Radiation, where does the pain go? Or does the pain go to anywhere? A for associated symptom. T for time or duration, how long you have the pain. E for exacerbating or relieving factor, so what makes it better or worse. And the S for severity, which we already asked. So these are our chest pain questions. So we will ask that when did it start? What were you doing at that time? Did it start suddenly? Is it for the first time? Is it continuous or on and off? Can you exactly point out the site of the pain? Does the pain go to anywhere? So that's radiation. You don't ask, remember, you can't ask medical jargon in exam. So you can't just say that, does the pain radiate? Radiate becomes a medical jargon. So always make it simple and layman term for any questions or any conversation you are having with the patient. So does the pain go to anywhere? Can you describe how does the pain feel like? This is really, really important question because the type or characteristic of the pain will define the case. If it is sharp, stabbing pain, we think of pericarditis. If it is tightness, heaviness, we think of acute coronary syndrome. Okay? If it is burning chest pain, we think of reflux. Anything makes it better, anything makes it worse, like deep breathing, coughing, or exertion. This is particularly important because if deep breathing or coughing increases the pain, it is pleuritic chest pain. Then we think of pericarditis or any of the respiratory causes. If it gets worse with exertion, then most of the time it is related to heart. All right? So we asked the pain questions. After the pain questions, we ask the associated symptoms. So along with the chest pain, do you have any shortness of breath, any racing of the heart, any nausea, vomiting, or excess sweating? What you are asking is that you're asking all the myocardial infarction question in here. And that's one of your main differential. So in the associated, you asked about any associated shortness of breath, racing of the heart, any nausea, vomiting, any excessive sweating. So we have done the HOPC. Our next thing is differential diagnosis, as many as possible. So we go to the pericarditis. So does the pain get worse when you lie down? Does it get better when you lean forward? Any recent flu-like illness? So normally 2 to 3 questions. So for each differential diagnosis, ideally 2 questions is enough. Okay, so you don't need to ask each and everything about that particular differential, just the most important one. So does the pain get worse when you lie down? Does it get better when you lean forward? Any recent flu-like symptom? Then we have aortic stenosis. We already asked about chest pain. We asked about shortness of breath. So only thing is left is dizziness or blackout. So any dizziness or sudden blackout. After that, we don't have much of the history that we need to take for cardiovascular. If you go back, you can see that already MI questions has been asked. We asked pericarditis. For aortic dissection, no more question needed. It based on the type of the pain. And we asked the aortic stenosis history. After that, we go to the respiratory causes. So for pneumonia, any fever, cough, shortness of breath. You already asked shortness of breath, so no need to ask it again. So any fever, cough. If you want, you can ask any noisy breathing. For pneumothorax, any trauma to your chest, any known lung condition like asthma, COPD. Because many times asthma, COPD patient can have spontaneous pneumothorax. So for pneumothorax, we will be asking these questions. So any trauma to your chest, any known lung conditions. For pulmonary embolism, any recent long distance travel, because that is the most common risk factor. And that's usually the common risk factor given in the exam as well. Any previous or family history of clot formation in your legs or lungs. So for pulmonary embolism, 2 questions is enough. Any recent long distance travel, any previous or family history of clot formation in your legs or lungs. After that, so pneumonia, pneumothorax, pulmonary embolism, that covers your respiratory causes. Then we go to the gastro. For reflux, any relationship of the pain with food. Do you get any burning chest pain or any heartburn or bitter taste in your mouth? So they get this heartburn, they get bitter taste in the mouth, they get like their mouth get full with saliva, which is called water brush or acidic brush. So you can ask these questions. So any relationship of the pain with the food, any heartburn, any bitter taste in your mouth. For esophageal rupture, which is uncommon cause, so you can ask any vomiting of blood. That will cover our reflux question. Then musculoskeletal for costochondritis. Is your chest sore to touch? For musculoskeletal chest pain, we can say that any heavy lifting or any excessive strenuous activity recently. So, given this is such a common cause of chest pain, always include this question. Many people forget this kind of common things. They want to look for all the serious things all the time, but the common cause of chest pain is usually musculoskeletal. So any heavy lifting or any excessive strenuous activity recently. After that, for neurological, any rash on your chest for herpes. And then you ask about the anxiety or panic question. So are you generally an anxious person? Do you worry a lot these days? Is there any stress at your home or work? If you find out that it is anxiety problem, then you will ask all the panic attack symptoms, which will be different kind of case. So you'll be saying that along with the chest pain, do you get shortness of breath? Do you get shaking, numbness around your mouth? Do you feel that someone is choking you? Or do you feel like you are dying? And usually these kind of episodes will be more and more like frequent episodes. So it will not be the first time. So they will always say, no, this has been happening like maybe 6 to 7 times in the last 1 or 2 months. That will lead you to think that, well, it could be anxiety attack, especially young female patient. Okay. Not a very common question in the exam, but again, we should always remember that this can be a possibility. If we can't find out anything from a history, then this is where we look into. After that, we finish with SADMA. So do you smoke, drink alcohol or any recreational drugs? Any past medical history? What are the relevant medical history for a patient who has chest pain? Diabetes, hypertension, high cholesterol, or any other heart disease. So any history of high blood sugar, high blood pressure, any history of high cholesterol or any heart disease, any family history of any heart disease, and do you take any regular medication? So now remember, if this is a task of 6 minutes, then you can ask all this history. So when you have a task of take history for 6 minutes, give your diagnosis and differential diagnosis, then that kind of broad history, you have the time to do it. But if there is multiple tasks, then you can't ask all of this, and examiners know that. So they are not actually looking for that you ask this 10, 15 differential diagnosis. In that case, you just focus on the important ones or relevant ones for that particular case. We will show you that. Okay, so these are your history for chest pain. Any questions so far? Yes, the serious risk factor, we are actually asking but with this. We don't need to add them anymore because serious risk factor includes smoking, diabetes, high blood pressure, high cholesterol, family history. All of these are serious risk factor. And only other thing, if we are sure that this is a like a ischemic heart disease, we can add, depends on the time we have. We can always ask about like, do you follow a healthy lifestyle? Do you do exercise? Those two we can add, but apart from that, serious risk factor will be covered by these questions. So to recapitulate the history, so first you introduce yourself, reassure, make sure patient is vitally stable, offer the painkiller, ask the chest pain question in detail, ask about the associated questions, which will mainly be the MI questions, then go to the differential. So we have 2 questions for pericarditis, aortic stenosis, 3 questions for lung causes, 2 questions for GIT, 2 questions for musculoskeletal, and then finish with shingles and anxiety questions. And lastly, finish with this. You thank the patient and then go to your next task. Your next task will be physical examination from examiner. So in physical examination from examiner, so you'll say that, dear examiner, I would like to do physical examination on my patient. On general appearance, is he comfortable or in distress? I would like to know about any pallor, cyanosis, or any edema. See that, like, I'm asking 3 questions max. How about the vitals? Pulse and blood pressure, please. Then examiner give it to you. Then again you ask, how about temperature, respiratory rate, and oxygen saturation? Can I know the patient's body mass index, please? Then I would like to check the neck for any raised JVP and any carotid bruit. It's really, really important not to miss the JVP and carotid bruit for cardiovascular cases. So ask the neck. So I would like to check the neck for any raised JVP or any carotid bruit. Then I would like to focus on the cardiovascular system. On inspection, is there any visible cardiac impulse? On palpation, is the apex beat normal in position? Any palpable thrill? Any parasternal heave? On auscultation, apart from S1, S2, is there any added sound like any murmur, any pericardial rub? So see that the cardiovascular system, because this is our main system, that's why we are asking this in detail. We are adding inspection, palpation, we're talking about auscultation. And that's how we need to ask one by one. So on inspection, any visible cardiac impulse? Examiner says no. On palpation, is the apex beat normal in position? Yes. Any palpable thrill, parasternal heave? No. Apart from S1, S2, on auscultation, is there any added sound like any murmur or pericardial rub? Pericardial rub is commonly found in pericarditis patient. Then respiratory system is another relevant system. So you will say, then I would like to examine the respiratory system. Is there equal air entry on both lungs? Any added sound like any bibasilar crepitation? Because bibasilar crepitation is important. We want to know if there is any sign of CCF. So on the respiratory system, is there equal air entry on the both side, or is there bilateral equal air entry? Any added sound like any bibasilar crepitation? And also respiratory system will cover your respiratory differential diagnosis. So you can always ask for any wheezing, any crepitations as well to rule out pneumonia. If you have some time, then you can ask that I would like to check the leg for any leg edema or any red solvent cough or any cuff tenderness. Because in the leg, the cuff tenderness will cover the deep vein thrombosis, which can be a cause of PE, and edema again for patient with cardiovascular disease, we always rule out edema or CCF in them. And lastly, you will ask about I would like to know if there is any office test available, such as urine dipstick, blood sugar level, and ECG. Now, it has to be a relevant office test always. Urine dipstick is not that important for a chest pain case. The more important is blood sugar and ECG. So just ask that I would like to do any office test. Do we have the blood sugar level or any ECG? That's it. Okay. Thank the examiner, and then you go to the patient again, and then you explain the condition. Now, so far you have learned about the cluster. Now we are going into the cases which is related to this chest pain. Is this clear for everyone so far? Okay. The first case is pericarditis. So we have got a 50-year-old tram driver presents with sudden onset chest pain for the last 2 hours. Now, looking at this question, there is no way we would think of pericarditis, and we shouldn't think about it. So we will think that this is most likely an acute myocardial infarction until we can prove otherwise. So 50-year-old sudden onset chest pain for 2 hours. Task is focused history, physical examination from examiner, and give you a diagnosis and differential. So let's have a look. So when you ask the history from this patient, they will give you these positive findings. So the positive findings in this case might be patient started to have the chest pain for 2 hours. The pain gets aggravated by lying down and deep breath. Now that's when you think of, no, it is not MI. So the pain gets worse with lying down and deep breathing, which is pleuritic chest pain, get better with leaning forward. It's a sharp stabbing type of chest pain. And they say that yes, pain radiates to the back and in between the shoulder blades. Now it can do. Sometimes pericarditis pain can be felt in the back. And patient also said that he had a flu-like symptoms a week ago. No other symptoms. So that's pretty much everything that we know, that we need to know to make a diagnosis of pericarditis. And then once you do the focused history, and then when you talk about physical examination from examiner, which will be exactly the same. So you'll be asking all of this. For pericarditis patient, the only finding you might get that they might say that yes, there is a pericardial noise. They will not say yes, there is a pericardial rub. They will say there is a pericardial noise, or you can hear a noise on the pericardium. That's the only thing that they will mention. Okay? Because if they say pericardial rub, you can make the diagnosis very easily. And they don't make it that easy in the exam. Now, sometimes they might give you the ECG. Sometimes they might not give you the ECG. Do we need a ECG to make a diagnosis of pericarditis, even after getting all this history? Yes, we really need to do a ECG because we need to know that whether there is something else. So ECG is must, but in exam, if they don't give us the ECG, that means it's not like we can't make the diagnosis. We can make the diagnosis, and during our management, we will say that we will do a ECG to see how is your heart doing. But we can make the diagnosis of pericarditis in the exam, even if they don't provide this ECG. Okay? So if you look at this ECG, what we say, we will have a good, so for all the candidates who has already enrolled into the course, in your portal, you must have noticed there is a ECG class that I have uploaded. So it's very difficult for us to do a complete ECG class in a clinical exam scenario because ECG is part of MCQ students, but you need to know the ECG. It's really important because they will give you ECG in the exam. So please make sure to go through that recorded ECG class, which is given in your portal, and learn about the ECG if you haven't done it. Our MCQ student, I'm sure you guys know it because we did a fairly good extensive ECG class in your course. But if someone in here who haven't done our MCQ class, then yes, I have given that ECG class there. Make sure you go through it. Okay. But today we are just going to discuss the important ones. So all of you should know what is ST elevation and everything. So this is the normal thing, right? So this is P wave followed by Q wave and then R and then T wave. Then again, the same thing goes on and on. So if you see this is the isoelectric line. So all of this should be in the same line. Most important is this one, which is the ST wave. So you've got P, Q, R, S, T. So this ST segment is our main worry for the chest pain. So if the ST gets elevated, we can see that in here, if the ST goes like this, then we are worried. Okay, so let's have a look if we can find out any ST elevation in this ECG. So V1, it's okay. If we see the V2, in the V2, we can see that this is the isoelectric line and the ST wave is here. That's ST elevation. This is our isoelectric line and the ST is here. Same, this is a ST elevation, ST elevation, ST elevation, right? So there is widespread ST elevation except V1. Now we come, so these V1 to V6, these are called chest leads. And then we have got another limb leads. So lead 1 to lead AVF, these 6 leads are limb leads. Now limb leads, lead 1 and AVL, these leads are called high lateral leads. And they are commonly associated with the chest lead. So chest lead are also known as anterior leads. Okay? So when you get ST elevation in the anterior lead, you should always look at what's going on in the high lateral lead because these are commonly associated with each other. So if we see lead 1 has got ST elevation, and we look at lead AVL, same. It has got a ST elevation, although slight, but it has. AVR, not important. We don't look at it. Lead 2, 3, and AVF. These are called inferior leads. If we look at lead 2, we can see lead 2 also has got ST elevation. Lead 3, nothing much. And lead AVF, yes, it has got a bit of ST elevation as well. So what you see here is that widespread ST elevation in almost all leads. When you get widespread ST elevation in almost all leads, that is pericarditis. So pericarditis ST elevation has a classic picture also. It will be concavity upwards, as if that someone can sit on it. So you can see that it's kind of a concavity upwards. That is a classic ST elevation for pericarditis as well. Okay? Why we are saying widespread? Because most of the time what happens that if you get ST elevation in anterior leads, in the inferior leads, you are supposed to get reciprocal ST depression. So normally in an acute myocardial infarction, if it is an anterior MI, where you will get ST elevation in these chest leads or anterior leads, ideally you would get ST depression in this lead 2, 3, and AVF. That is called reciprocal changes. Vice versa means that if inferior MI happens, so if there is ST elevation in the lead 2, 3 AVF, in inferior MI, there will be reciprocal ST depression in anterior, like in anterior leads. Okay, so either it is reciprocal ST depression or it will be totally normal. So they don't usually commonly, like all of them doesn't have a ST elevation. It's very, very unlikely. So when we don't see these reciprocal changes between anterior and inferior leads, then the main thing that comes into our mind that this is most likely pericarditis because of the widespread ST elevation. Okay? Makes sense, everyone? So, how we are going to explain pericarditis? So you'll say, now this is important. Understand how I am explaining these things. So you'll say, Jack, most likely you are having a condition called acute pericarditis. The number one thing is that most likely, you as a junior doctor, you never say that, Jack, you have a condition called pericarditis, because you might not be sure. So you always say that, Jack, most likely from history and physical examination, you are having a condition called acute pericarditis. Do you know what it is? No, doctor. Well, let me explain. So it's a condition where there is inflammation of the outer layer of your heart called pericardium. Now, it's important to understand that we can say the medical term, but the medical term that we say, you need to explain that. Because if you don't say that it is acute pericarditis, examiner doesn't know the diagnosis that you're thinking of. They can't read your mind. So if you say that, Jack, you have a condition where you have got inflammation in the outer layer of your heart, this is going to pass you? No, no. You have to say the exact diagnosis and then you explain it in a layman term. That's really, really important. Sometimes people, because they know that it has to be layman term, they become so much layman that it becomes difficult to understand what they're talking about. So you don't need to be that layman that examiner also can't understand what you are saying. So make it a combination between medical jargon and layman. The idea is, if you use a medical term, you explain it. Like I said pericardium, but I explained it is the outer layer of the heart, and that makes sense. So it's a condition where there is inflammation of the outer layer of your heart called pericardium. While you are explaining it, you will have a pen and paper with you. You can quickly just draw that this is a condition where there is inflammation of the outer layer of your heart, which is called pericardium. See that I'm drawing and I'm also explaining. That saves time. Most likely, it's due to the recent viral infection that you had. Sometimes this pericarditis can be due to other causes, like if you have some some issues in your kidney, if you have connective tissue disease like lupus, if you have any recent chest trauma, or sometimes even it could be due to some suspicious growth or cancer. And sometimes it can happen without any reason as well. But in your case, it looks like that it's most likely due to your recent viral infection, which is the most common cause. So please don't get scared. As the covering of the heart is inflamed, it's causing this sharp stabbing chest pain, which gets worse when you lie down and it gets better when you lean forward. What we are discussing? We're discussing the clinical feature. So we gave the diagnosis, we explained what it is and what could be the cause of it. We talked that it is most likely virus, could be due to other causes. Now, see this, I used a bit of like a dull color in here. The reason is that it is not always important that you need to mention this. If you think that you are running out of time, forget about explaining this dull color thing. I always put these details for you to know, but these are like if you only have time. If you don't have time, as long as you mention that it is most likely due to the recent viral infection, you are okay. Unless the task specifically mentioned that explain the diagnosis with the cause. There is another task you get sometimes. So if anytime the task is explain the diagnosis with causes, explain the reason of the diagnosis. In that case, these are important. That's why I keep it in the note, because sometimes they do that. Okay? You explain the clinical feature and then you give some differential. Let's say that task is only up to diagnosis and differential. How will you do that? So you will say it could be due to other reasons as well, like then you go to all the differential diagnoses you have asked, as many as you can. So it could be due to acute myocardial infarction or heart attack. But the chest pain that you are mentioning is not heavy, tight feeling, and your ECG does not show any change, and also you don't have any associated shortness of breath, sweating, nausea, vomiting. It could be another condition called aortic dissection. In that case, the chest pain will be severe, tearing, and central, which will go to the back. It could be due to aortic stenosis, which is a valvular heart disease, but you don't have any chest pain or shortness of breath on exertion, or you don't have any dizziness. It could be some lung-related condition like pneumonia or chest infection, but you don't have any fever or cough. Could be clot in the lungs, but you did not have any risk factor, and your chest pain does not fulfill the criteria of that. Could be pneumothorax, where there is air outside your lung, but you don't have any injury to the lung, and also the examination I have done does not go with pneumothorax. It could be related to reflux, but you don't have any burping, belching, no burning chest pain. It could be peptic ulcer disease, but you don't have any pain related to food, and you don't have any tenderness in your tummy. Could be musculoskeletal, but your chest is not sore to touch. You did not have any chest trauma, so unlikely to be rib fracture. Could be a shingles, but you don't have any rash. So these are all very unlikely in your case. So did you understand? Like, this is how you are supposed to explain the differential. In 1 minute, you can do it. And the only way to do it is if you have a very, very good knowledge about these conditions. Without that, you'll forget about this. Okay? So visualize in your eye that these are the differential diagnoses I have asked, and that's how I'm going to explain the differential. And that is only needed if the task is diagnosis and differential. If task is not about differential, then if you don't give differential, they can't fail you. Okay? Let's say there is a management in here. How are you going to say it? So you'll say that, let me assure you, Jack, that it is not a heart attack. That's really important to say. But to confirm my diagnosis and to exclude heart attack, I would like to keep you under observation in the hospital. I'll call my senior and a heart specialist will come and see you. In the meantime, I'm going to arrange some investigation like full blood count to see if you have any infection marker. I'll check your inflammatory marker. I'll check your kidney function because that can be sometimes a cause of pericarditis. I will do a repeat ECG to see if there is any other changes happening in your heart, and also a cardiac enzyme to rule out heart attack. See that I'm explaining why I'm doing it. Now again, is it mandatory? No. If you are running out of time, as long as you are mentioning the name of the investigations, this is mainly for examiner, not for patient. So you don't need to explain it. But if you have time, then yes, do this because it just shows that you know why you are doing these investigations. And never just do investigation without any cause. The heart specialist might want to arrange another test called echocardiogram of the heart, which is nothing but a scan of the heart to rule out any fluid collection around your heart known as pericardial effusion, and also to rule out any inflammation of the middle layer of the heart called myocarditis. So these are investigations we would do in a pericarditis patient. We do the blood test, we do an echocardiogram to rule out any pericardial effusion because that can happen, and also to rule out possibility of myocarditis. Once it is confirmed to be pericarditis, a specialist will most likely start you on a combination of colchicine for 3 months, which is an anti-inflammatory medication. So what happens that in pericarditis patient, we give a combination of colchicine. That's also act as an anti-inflammation. But with that, you need to use another anti-inflammatory, either aspirin or ibuprofen. So this is from therapeutic guideline. And therapeutic guideline is what we would follow for any management for your clinical exam. And in your course, you will receive all the important management from therapeutic guideline and any other Australian guideline that we follow, especially RSCGP or sometimes John Murtagh. But mainly we focus on therapeutic guideline. Okay. So once it is confirmed, then specialist will start you with a combination of colchicine for 3 months and an anti-inflammatory medication such as ibuprofen for 1 to 2 weeks, depending on your inflammatory marker. Most likely, you'll be able to go back home after the test results are back. But please avoid any exercise for the next few weeks for proper healing and to prevent worsening of the inflammation. I want you to know that this is not an uncommon condition, and with proper treatment, this can be easily managed. So you don't need to worry about it at all. You are here with us, and we are going to manage this for you. Do you have any questions? So always finish with something really nice, something reassuring, so that patient can give the trust on you. Without this kind of trust, patient will not be satisfied. So it's really important that how you end your case. Try to end it like this, okay? So Dr. Aryan, that is actually what we would need to say. Okay, so colchicine plus either aspirin or ibuprofen. That's the therapeutic guideline. I don't know anything else. That's it. That's what we will give to the patient. Okay. All right. So that's all about pericarditis. Are you guys with me so far? You are understanding that everything that I am saying? It can be too much sometimes, but I'm sure you're enjoying it because I'm trying my best to give you 100% for these cases, which are super important. No need to know the dose. So dose is not needed. You'll see that I haven't mentioned that when I talked about it, right? So only the name is enough. Name and duration. Okay, now the most important case for exam, acute myocardial infarction. So you have got a 55-year-old man comes to your ED with a sudden onset crushing chest pain. You are in a tertiary hospital. So there are multiple cases that comes in exam under acute MI in different ways. So this is one of the way. Take history, ask for investigation from examiner and explain to the examiner. Explain the likely cause of his chest pain and immediate management to the patient. So history, investigation from examiner and explain to the examiner, likely cause of the chest pain and immediate management. So you need to always remember what is the main task. That's one question where they haven't given any ECG at first. The second question like this, same question, 55-year-old ED, sudden onset chest pain. You are in a tertiary hospital, so we should always know where we are because management depends on it. ECG is given below. So they have given an ECG on the next page. If you look at the ECG, tell me what you see. So if you look at V1, V1 has ST depression. V2 has ST depression. V3 has ST depression. Okay. V4 has got slightly ST elevation. V5, V6, yes, they have got a little bit ST elevation. Lead 1 and lead AVL. Lead 1 is normal. Lead AVL, we can see there is ST elevation. So it's mostly ST depression, mostly ST depression in the anterolateral leads. Now, if you look at inferior leads, lead 2 has got massive ST elevation, lead 3 massive, lead AVF massive. So that's what we have got. So you can see that most of the anterolateral lead is showing this reciprocal ST depression. So this is inferior MI or inferior ST elevated MI because you can see that lead 2-3 AVF has got massive ST elevation And the other leads, the anterolateral leads, are showing ST depression, which is reciprocal change. Have a look on this one. Lead V1, no ST elevation. Lead V2, we can see that yes, there is ST elevation. Lead V3, definitely ST elevation, and we can see a J point. This is called J point. Lead V4 has got ST elevation. V5 has got it. V6 has got it. So this is widespread ST elevation in these leads. Let's check 1 and AVL. 1 has got it. AVL has got it. Let's check the 2-3 AVF. 2, nothing. 3 has got ST depression. AVF, normal. So lead 2-3 AVF, as you remember, reciprocal change is not must. It can be normal or they can have depression. So this is called extensive myocardial infarction because almost all leads of the anterior and lateral has ST elevation. So this is extensive anterior MI. Okay? Or yeah, we can say anterolateral MI. Same. So these are actually your ECG, how it will be in exam. So they have given you the ECG already in the stem. If they give you the ECG in the stem, then you already know in that 2-minute outside that this is a case of ST elevated MI. So you need to take a brief history. See that they are not asking for a whole lot of history anymore. Brief history, focused history, relevant history means that they just want to know that particular questions, not anything else. Just a brief history about the chest pain will be fine. Explain ECG to the examiner. And then, so in here, they already said, they did not say that ask for investigation. They just said explain ECG to the examiner. Explain the likely cause of his chest pain and the immediate management to the patient. Okay? All right, so this is a patient with 55-year-old man who comes to the emergency department with a sudden onset of crushing chest pain, right? You are in a tertiary hospital, ECG given below. We already know that this is a ST elevated MI. Our task is to take a brief history from the patient. With brief or focused history, we just make sure that just within 4 minutes, we are going to finish the history. It will not be any other differential diagnosis because we don't need to. We already know that it is a ST elevated MI. Explain ECG to the examiner and then explain the cause of his chest pain and the immediate management to the patient. So that's another case. There is a third case. Let me see if I have got the case. This is the third case. It's a 50-year-old male presented to you with a chest pain started 30 minutes ago. ECG given in the next page. You are in a rural hospital. The nearest tertiary hospital is 4 hours away, and you have no option of transfer at the moment. Take a history. It's also brief history from the patient. Explain the ECG to the examiner and explain further management. So these are the 3 cases which comes in exam under MI. And there are different way of managing them. Okay. Now let's first go to the tertiary hospital management. Then we come back to our rural hospital case. So in the tertiary hospital, we have a case where we don't know what's the cause because they haven't given us the ECG. The second case, we know it is already a ST elevated MI. Okay. So how we're going to start it? So definitely your history will be the same way how you have done it. So you will get that this patient has got acute onset of severe left-sided chest pain. It's crushing in nature, radiating to the neck, jaw, left arm. It is for the first time. There is associated shortness of breath, nausea, vomiting. You might get a positive smoking history and all. Okay, so this goes with myocardial infarction pain. Now, how we are going to start the first and second case. So when we get a patient with a crushing chest pain, we think that this is an acute MI. Even if there is no ECG given, this is likely to be a MI case. But still, we are not fully sure without the ECG. That is the only difference. So the first case, our history will be the same as the cluster. The first case means where we don't have the ECG. The second case is where we have already got a ECG of ST elevated MI, right? So in the first case, first you introduce with the patient, and then you will say that well, hi Jack, this is Dr. Arshan. It's very nice to meet you. I understand from the note that you have a chest pain. I'm so sorry to hear that. The chest pain can be very scary, but now that you are here, I'm going to take care of it. So before I ask you any more questions, please let me make sure you are stable. So I'm going to talk to my examiner and come back to you. So you turn to the examiner, and examiner, is my patient vitally stable for further history? Now, examiner can say, proceed. If examiner say proceed, or examiner say what you want to know, or examiner says, yes, patient is vitally stable, what will you do? This kind of patient, whether they are stable or not, we take this patient to the resuscitation cubicle if it is an emergency department. So in emergency department, we call it resuscitation cubicle. If it is GP setting, we call it treatment room. Okay? So because these are in the emergency department, so you will say, so whatever the examiner says, unless examiners say that unless examiners say stick to your task, then it is a different thing. If examiners say stable, your patient is stable, proceed, okay, or what do you want to know? Then patient gave you all the information and you found patient is stable. Whatever it is, this patient will go to the resuscitation cubicle. So the first case where we don't know the specific cause of the pain, we will say that examiner, given the crushing chest pain in a 50-year-old, I would like to take my patient to the resuscitation cubicle, attach him to a cardiac monitor, and ask the nurse to do an ECG, secure an IV line, take blood for full blood examination, inflammatory marker, and a cardiac troponin, please. Okay? So what we have done, we don't know what this patient has got. We don't know whether it is a myocardial infarction. We don't know anything. We just know that this patient is a 50-year-old with a crashing chest pain. Given we don't know it is MI, we haven't started aspirin, we haven't started any monotherapy yet in the first case. Okay? Now, the second case is we know that this is a ST elevated MI patient already. So we will say, I would like to take my patient to the resuscitation cubicle, or you can say, given the ECG showing ST elevated MI, I would like to take my patient to the resuscitation cubicle, attach him to a cardiac monitor, start him on aspirin 300 milligram, secure an IV line, take blood for full blood examination. I don't need to do this anymore. So take blood for full blood examination and cardiac troponin. You can do a coagulation profile, blood group and cross matching. Those we can do. But just say that take blood for full blood examination and cardiac troponin. And also if my patients, now, if you know from the examiner that their saturation is low, then start the patient with oxygen. How much low? If the saturation is less than 92%, then we start the patient on oxygen. Okay? So the second case, we know that this is a ST elevated MI. So for this purpose, the life-saving measures, every minute that we are waiting, we are actually wasting some cardiac muscle if it is a ST elevated MI. So aspirin has this timeline. That means as soon as you start the aspirin, you are saving some of the cardiac muscle. So you say that I would like to take my patient to the resuscitation cubicle, attach him to a cardiac monitor, start him on 300 milligram aspirin, secure an IV line, take blood for full blood exam, cardiac troponin, and then I'm going to talk to my patient. Okay? If you know from the STEM or from the examiner that oxygen saturation less than 92, then offer that you will also start him on oxygen. Does it make sense to everyone, like the starting? Because this starting is different from any case that you will do in the medicine. It's same in a way that if examiner gives a patient who is unstable, like when you ask that examiner, I would like to know if my patient vitally stable. If it is an unstable patient, you always take them to the resuscitation cubicle. Okay, and based on the problem, sometimes if a patient is in shock, you might start the patient with IV fluid. So based on the case, we say what we will do next. But any unstable patient will go to the resuscitation cubicle. We will attach them to the cardiac monitor. We do an ECG, take the blood, secure IV line, start IV fluid if needed. So those are always done for unstable patient. Okay. They don't give a lot of unstable patient in the exam. So don't get scared about it. But for MI case, definitely we will take them to the resuscitation cubicle. Now, we have done that. The next thing is history. We start with the pain question. So offer painkiller. The first case where you don't know whether it is a MI or not, you just say that you are going to offer painkiller. The second case where it is ST elevated MI, offer IV morphine to that patient. Then you start with your chest pain questions. Same questions you will be asking. The first case, because you don't know the cause, you need to ask a proper history. That means your history will be detailed history like the format we have shown you. The second case, where we already know the cause and they said focused history, we don't need to ask differential diagnosis question in that case anymore. All we need to do, we ask about the chest pain questions in detail. We will ask about the associated questions. And then we will ask the cardiovascular risk factor question. Risk factor means that you ask about their smoking, alcohol, ask about their medication, ask about their past medical history, all of those, diabetes, high blood pressure, ask about their exercise, ask about do they maintain a healthy balanced diet. Okay, ask about whether they are under any kind of stress at the moment, because stress is a cardiac risk factor. And then ask about, are they overweight by any chance? Now, do we really need to ask it? When we see the patient, we can understand. So it's not mandatory to ask. And in your physical exam, when you ask the BMI, you will find out. So no need. So past medical history include the exercise. So do you do exercise regularly, or do you normally have a sedentary lifestyle? Do you have a healthy balanced diet? Are you under any kind of stress? And then family history of any heart condition. So this will be the only history. So the history you can finish very quickly, sometimes even in 2 to 3 minutes, because the management will take a long time in that case. Okay, so we have done the history. The next task is, first case, they ask investigation from examiner. For a chest pain case, what investigation you will ask from the examiner? Your number one investigation should be ECG. Along with that, if you want to ask for some blood test, you can. So you can say that, dear examiner, I would like to order a ECG for my patient first, And also, I would like to know if there is any blood test available, like what blood test we would do. Full blood examination, inflammatory marker, like pericarditis might have a raised inflammatory marker. Then we check their kidney function. That's always important part of cardiovascular investigation. Then you can ask about cardiac enzyme, which is the troponin, very important. Okay, so these are main: full blood, ESR, CRP, kidney function, cardiac enzyme. And then if we want to go a little bit more, we ask blood sugar. We ask about whether they have lipid profile, because important for cardiovascular status. All right. So all of these are relevant. We are not doing anything irrelevant. And even if we want to do a chest X-ray to rule out any respiratory causes, that's also fine, because they asked you to ask for investigation. And these are all investigation we can do. Okay. But based on your history, if they say ask relevant investigation from examiner, that becomes a fully different task, because relevant in this case is ECG and cardiac enzyme. That's it. Nothing else is relevant at the moment. Okay? So understand what they're asking in the task. But the main thing is ECG. So let's say that they have given you the ECG and you need to explain the ECG to the examiner. How we are going to do that? So ECG explanation has a definite way to do it. So you'll say that I would like to describe the 12-lead ECG of my patient, Mr. John or Jack, a 55-year-old man who came with a sudden onset crushing chest pain. So you just say that I would like to describe 12-lead ECG of my patient who presented with a sudden onset chest pain. Now, when we explain ECG, there is a format that we always follow. The format is, we talk about the heart rate. Is it regular in rhythm? We talk about each and every part of the ECG. That means, how is the P wave? How is the QRS complex? Is there any ST elevation? How about the T wave? And how is the QT interval? So all of these, one by one, we will need to explain to the examiner. So you need to know how to calculate heart rate, especially if it is a regular rhythm in exam, how to do it quickly. So let's talk about this a little bit so that you get a proper idea. So we know about P, Q, R, S, T. Just one thing is, what is QT interval? QT interval is the starting of the Q wave and end of the T wave. This whole thing is QT interval. There is a case in exam which is prolonged QT interval. So that's why we need to look into this. So how we calculate heart rate in exam? The easiest way is check for, so this is one R wave and this is another R wave. In between two RR interval, how many large square you can see? So in here, the largest square 1, 2, 3, 4, 5, 6, 7. 7 largest square. So you just do 300 divided by the large square in between two RR interval. So it's 7. So if you do it, it will be around 42. Now it's a good idea to know this beforehand, rather than like if you need to calculate that, and in that time it will be very time consuming. So what we say, that if you see there is only one large square, so if the RR interval was here, if one large square, then it's 300 divided by 1. So the heart rate is 300. So one largest square 300. If it is two largest square, then it's 150. Three largest square 100. Four largest square 75. 5 largest square 60. So at least know this, because usually it will not be more than 6 or 7, because that becomes very like significant bradycardia. Okay, so if you just know that if it is 3 largest square, I know heart rate will be 100, and you can easily just say that rather than measuring it in the exam. Okay, does it make sense? We also need to know, yeah, speed always 25. In the 12 lead ECG, they will give you speed is always 25, so you don't need to worry about that. Now, we need to know that what is sinus rhythm, because after heart rate, our next thing is to check the rhythm. So rhythm means that if you have got regular RR interval, it means it is regular rhythm. So we can see that between each RR interval, there is 1, 2, 3, 4 large square. So same in here, 1, 2, 3, and together this is 4. 1, 2, 3, 4. So if there is same regular interval RR, if there is RR interval is equal, it's a regular rhythm. And if you see this one, definitely you can understand this is irregular. So important to know that how to know what is regular and irregular rhythm. The next thing after that is P wave. P wave, normally you just see that whether you can see the P wave or not. So P wave present or absent. Because absent P wave is a common finding in atrial fibrillation patient. Then you go to the QRS complex. In QRS complex, remember the normal QRS complex is usually just one small square. So you will see that this is normal, just one small square, that is normal. And then if it is more than 3 small square, then we call it wide QRS complex. So this one you can see that the QRS is that wide. So more than 3 small square, we will say it is a wide QRS. And narrow QRS is that like you can't even see anything. So narrow QRS is even less than 1 small square, which is a finding of supraventricular tachycardia. Okay, so remember normal QRS is ideally 1 to 3 small square. If it is more than 3 small square, it is a wide QRS. If it is less than 1 small square, it is a narrow QRS. Okay, so now you come here in this ECG. So you'll explain that the heart rate of my patient is 75 beat per minute. Now in here it is difficult. In your exam, they will give you a long lead. The long lead will be lead 2 where you can easily find out the rate. Okay. So in here, if we want to really know, then we will need to find out where is the RR interval. So this is the R and that's the R. So 1, 2, 3, 4. We know if there is 4 large square, it's 75 beat per minute. So heart rate 75 beat per minute, and then it is regular rhythm. Then we can see there is normal P wave, right? So P wave is normal. We can see QRS complex, although it is very small in here, QRS complex is normal. The main thing is ST elevation in this case. So you'll need to mention where you see the ST elevation. So ST elevation in lead V2, V3, V4, V5, V6, lead 1, lead AVL. That's the main thing. And then if there is anything in the lead 2, so lead 2 is normal. 3, you can see there is a bit of ST depression in here. And that's normal in AVF. So they will usually give you a bigger ECG. It will not be this difficult. So whatever you see in these leads, ST elevation, ST depression, you mention that. And that's the main part of this ECG presentation. And then explain T wave is normal, QT interval is normal as well. If you think you're running out of time, and that is a chest pain case, I would say that you can, like even by mistake, if you say that T wave, like QT interval is normal, most of the time it will be normal. But again, it's better idea that you check all of this and mention whether there is any problem in here. But the main thing is whether you see ST elevation or depression in these leads. That's what you need to mention. But when there is a ECG presentation to the examiner, this is the format we need to use. So you say, what is the heart rate? Is it regular, irregular rhythm? How about the P wave? What is the QRS? Is there any ST elevation or depression? How is the T wave? How is the QT interval? Okay. Is it all normal for everyone? No, you don't need to give the diagnosis in here. So when your presentation of ECG is what you see there. If you say to the examiner that I think that this patient has got ST elevated MI, it is fine. You can say that, but it is not must for you. As long as you are presenting it, you are okay. Now, management. So in the management part, you will need to explain in detail. So your management should be the main part of this case. So you'll say that, thank you so much for waiting, John. Based on the nature of your chest pain and according to the ECG, most likely you are having an acute myocardial infarction or a heart attack. John, I'm so sorry, but it is a serious condition. John, are you with me so far? Are you understanding? Do you know what is heart attack? Yes, I know about it, but I never actually thought how bad it can be, doctor. Can you tell me what's going on? Well, John, let me explain. Heart attack happens when blood flow to a part of the heart gets blocked. So you should make it very simple. Heart attack means blood flow to part of the heart is getting blocked. Let me draw a picture for your better understanding. So you can always draw a picture like this is your heart, and your heart has got several blood pipes like this. Okay? And then you can say your heart is like a pipe to your garden. So now it's only if you have time. Like Australian loves any reference to garden, any reference to their garden pipes, hose, and everything. So if you are in Australia living for a while, you know that Australians love their garden. So if you can relate their health with their garden, they will be extremely happy. So we try to explain things in their own way so that they can relate. So you can say that it's like when a pipe to your garden gets blocked, then no water can reach the plant and they start to dry out. Similarly, without blood, the heart muscle starts to die and it can lead to life-threatening complication. Okay, so it's a very easy and simple way of explaining heart attack to a Aussie who's most of the time they are dealing with their garden. Okay, so and you will see that like most of the Australians they know this, they understand what you're talking about. They will. That is must. Without this, they are not Australians. So it's like when a pipe to your garden gets blocked, and you can see that if it is blocked, no water can reach to the plant and it start to dry out. Similarly, when your heart gets blocked, it cannot get any blood supply. So the heart muscle start to die and it can lead to life-threatening complications, John. So that is the explanation that I would like you to do if you can. Now, if you are running out of time, you don't have like 1 minute to explain this, then you can do a short explanation. There is a short explanation I always write here. So, John, thank you for waiting. Based on the nature of your chest pain and according to the ECG, most likely you have an acute myocardial infarction or a heart attack. John, I'm so sorry, but it is a serious condition. Do you know what it is? Do you know what is heart attack? No, doctor. Well, John, heart attack occurs when blood flow to a part of the heart gets suddenly blocked, leading to permanent damage to that part of the heart if not treated promptly. Now, that is the easiest and shortest way to explain it. If you have some time, you can always add this line. This line, like examiner will love it. Australians will love it. So if you have time, add this. Then you say this typically presents as a sudden onset of severe crushing left-sided chest pain, which can go to your left arm, neck, and jaw, associated with nausea, vomiting, excessive sweating, which all of these you had. John, please don't get scared. We have one of the best team of cardiologists in this hospital. Now remember, this is a tertiary hospital, that's why we are saying it. If it is a rural hospital, we can't say it. Moreover, you have come within 12 hours of your symptom. So with proper intervention, this can be managed very effectively without any serious complication. And this is right. You are not saying anything illogical or impractical. Okay, so this patient came within 30 minutes of chest pain or within 2 hours of chest pain. So you can always reassure this patient saying that we have the best team of cardiologists, as you have come within 12 hours. With proper intervention, it can be easily managed. So for further management, I'm going to admit you to the hospital. I'll discuss this with my senior and call the cardiologist and the catheter lab who will come and review you. If this is a key point that you mention, that you are going to inform the catheter lab, because this patient can have a PCI, right? In the meantime, I have already taken you to the resuscitation cubicle. I have taken blood for necessary investigations. I will give you an aspirin, 300 milligram to chew to prevent any further clot formation. It depends that if it was the second case where you have already given aspirin, you will just say that I have already given you an aspirin, which is a 300 milligram tablet to chew, and that's going to prevent any further clot formation. In the first case, you haven't given anything, so you just say now all the things. So I'm going to give you an aspirin, 300 milligram tablet to chew to prevent any further clot formation. I have already started you on IV morphine for the pain and will repeat it until you feel comfortable. The cardiac monitor is also showing your oxygen level. If it gets lower than 92, I will give you oxygen. Also, if you have ongoing chest pain, I will start you with a nitroglycerin spray, which you can put it under the tongue, and we can repeat it 3 times every 5 minutes. See that this is the monotherapy. We're talking about morphine, oxygen, nitrate, aspirin. That is the immediate treatment. If you remember your task now, if you go to the task was explain the cause of his chest pain and the immediate management. Your immediate management is this: explaining what is going on, calling the catheter lab, and then start all the MONA. A specialist might also start you on another blood thinner called clopidogrel and also a IV blood thinner, which is enoxaparin, to prevent any further clot formation. All patients with ST elevated AMI, along with the aspirin, they will be started with clopidogrel or like any other antiplatelet, could be ticagrelor or could be prasugrel, but there will be an antiplatelet and another anticoagulant, which is heparin, which is now we can say enoxaparin or dalteparin. So you will also say that a specialist might also start you on blood thinners such as clopidogrel and also enoxaparin, which is given IV, which is given subcutaneously or under the skin to prevent further clot formation. The definitive treatment of this condition is to remove the clot and restore the blood flow, which is what we call percutaneous coronary intervention or thrombolysis. As you presented within 12 hours, most likely a specialist will arrange for percutaneous coronary intervention or PCI, which is the best treatment for your condition. In this procedure, a thin tube will be passed through your wrist or groin to reach your heart and find the blocked pipe. So you know how we do the PCI. So we are going to put a catheter through the femoral artery or the radial artery, and then we guide that catheter into the coronary artery. And then we put a dye there, and the dye can find out where exactly is the block. And then we can put a balloon there, or we can put a stent in that blocked artery. So you need to explain this in a very nice and simple way. So a thin tube will be passed through your wrist or groin to reach your heart and then find the blocked artery. Then the specialist may use a small balloon to open it up or place a tiny mesh tube known as a stent to keep it open. Please don't get scared because you will be under sleep during the procedure and you will not feel any pain. John, I understand this may feel overwhelming right now, but please know you are in good hands. We will do everything possible to take care of you and manage your condition safely and effectively. If you want to call your wife, your partner, friends, or family members, please let me know. I will be more than happy to bring them here. John, do you have any questions? Okay, so this is going to be your explanation of acute MI management in a tertiary hospital. Does it make sense for you? It's not about 120 minutes, so I'm going to show you the exact management that we do for MI. So we start aspirin for everyone. Then for ongoing chest pain, if a patient is hemodynamically stable, remember, unstable patient, we can't give glyceryl trinitrate. So the main thing is that if a patient's blood pressure less than 90/60, or patient took Viagra, sildenafil, within the last 24 hours, we can't give them GTN. Otherwise, we can give them GTN, which is a sublingual spray, and you can give it every 5 minutes for 3 times at a time. If it's still chest pain, then we have option of IV fentanyl or IV morphine. That is the monotherapy. And we also mentioned, so this is ETG guideline. So if oxygen saturation less than 92, then only we will give oxygen. Not everyone will need oxygen. Now, this is the management that we want you to understand so that you never forget about it. So if you get a ST elevated MI patient, first thing is aspirin. Second is plan perfusion therapy, which means you need to plan whether this patient can have a reperfusion. And reperfusion include PCI or thrombolysis. The next thing that you need to find out is PCI available within 120 minutes of first medical contact. Now there are 2 timing that's come into our mind. One is 12 hours. So reperfusion is only done if patient comes within 12 hours of chest pain. So if patient comes after 12 hours, reperfusion is usually not needed. And reperfusion means that urgent PCI or urgent thrombolytic medication. Now the question is, patient came within 12 hours, but can you arrange PCI within 2 hours of first medical contact? The first time patient contacted you or first time patient came into your hospital, from that time, can you arrange PCI within 2 hours? This is where the rural hospital case comes. Rural hospital case says that your next tertiary hospital is 4 hours away, which means it's more than 2 hours. That patient, you can't send the patient for PCI anymore. So if you can't arrange PCI within 2 hours, your best option is thrombolytic therapy. And thrombolytic is those altiplase, retiplase, those ones. If you can arrange PCI within 2 hours, then yes, you go for the PCI. You can all see, this is what I was saying. So we add a dual antiplatelet therapy, which is your clopidogrel, ticagrel, or prasugrel, any of them. And then you also add a parenteral anticoagulant therapy, which is the heparin. All of these will be added. Now, if you can't do PCI, then you do thrombolytics. Before giving thrombolytics, you need to make sure they don't have any contraindication of thrombolytics. So in that rural case, we need to find out if the patient has any contraindication to thrombolytics. If not, then we can give thrombolytic therapy. Along with the thrombolytic therapy, they will also get clopidogrel, they will also get heparin. Okay. If the patient has contraindication to thrombolytic, then you can't do anything. You just send the patient to the nearest tertiary center who has the PCI. Does it make sense, guys? Like, do you guys now have a clear picture of ST elevated AMI management? Any questions? So if patient comes within 12 hours of chest pain, we can give PCI or thrombolysis. To choose which one we can give, we need to find out whether we can give PCI within 2 hours of first medical contact. If we can, then we go for PCI. If we can't, then we go for thrombolytics. Nice and easy. Okay? So these are the dual antiplatelet therapy. We know aspirin, we can give any of these. You don't need to know the dose. How to know if patient has contraindication? We are going to ask it. So these are the contraindication to thrombolytics. So there are absolute contraindication and there are relative contraindications. So definitely in the history, you need to find out whether they have any contraindication. So the contraindications are any previous history of brain hemorrhage. So any hemorrhage or any bleeding in the brain. Do the patient have any known malignant intracranial neoplasm? So any known cancer in the brain. Any known structural vascular lesion like AV malformation. You don't need to ask it. Patient will ask. You can ask that, do you have any known brain condition? Any history of ischemic stroke in the last 3 months? If you suspect associated aortic dissection, any active bleeding disorders, any significant head injury or facial trauma in the last 3 months. So these are the contraindications which we are going to ask in that rural hospital case. So you need to memorize them. Okay? So we will come into that. And there are lots of other relative contraindication. You can give it a read. The thrombolytic therapy that we use for ST elevated AMI are these: alteplase, tenecteplase, and all. You don't need to know the dose, just the name. These are the parenteral anticoagulation. So we use the heparin. So the heparin, the common one is enoxaparin. So enoxaparin, we can use intravenously. We can use subcut. Any of them are fine. So let's finish with the MI rural case so that we can finish the chest pain totally. So this is the same case, but you are in a rural hospital. Your nearest tertiary hospital is 4 hours away. There is no option of transfer. They have already mentioned it to you. So do not say that you are going to transfer the patient for PCI. You will fail this case. So history is same like before. Only thing that we have added is the contraindication of thrombolytic therapy in this case, in the history. So any history of a stroke or bleeding in the brain, any bleeding disorder, any history of brain tumor or any other brain lesion, any history of head injury or any injury to your face in the last 3 months. That covers all the contraindication question. Okay? So at least the absolute contraindication. If you want to add a little bit more, you can. But these are the main thing. Any history of bleeding, any bleeding disorder, brain tumor, stroke, and head injury. If it is aortic dissection, you will already know from the history. You don't need to ask it. So explanation. Your explanation is the same. It is a ST elevated AMI. So you explain this is myocardial infarction and all and all. In the management, you will say that, if you remember that we say that as part of the management, this hospital is a rural hospital, okay? And we don't have the best management, which is the percutaneous coronary intervention for you. So instead of the percutaneous coronary intervention, we're going to do the thrombolytic therapy. So I will explain what we are going to say, but just remember, that in this particular case, you will not talk to a catheter lab. You don't need to arrange for PCI. After the monotherapy and adding the clopidogrel heparin, then you'd say that, first of all, this is a rural hospital. You will talk to your senior, and also you are going to talk to a cardiologist in the tertiary hospital so that they know that you are doing this. And then you will say that as part of the management, because you came within 12 hours, we have an option of going for percutaneous coronary intervention or thrombolytics. But because it is a rural hospital, we don't have that option. So our best option at the moment is giving you a medication which is called thrombolytics, which is going to dissolve the clot that's blocking your heart. Okay? So that's what you need to explain. So if you go back to our main management where we have explained, so you will explain all of this. You will explain about that. Then you will say the definitive treatment is to remove the clot and restore the blood flow, which is what we call PCI or thrombolysis. As you came within 12 hours, most likely, then in here you will say that as you presented within 12 hours, the best management for you would be percutaneous coronary intervention, which is passing a small balloon or a mesh tube into that blocked artery to keep it open. See that I made it now smaller because this is not our main management. We are not discussing all of this. You just say that this was the best option, but if we need to transfer you to the nearest tertiary hospital, it's going to take us 4 hours. And in that 4 hours, your heart muscle will get more and more damage. So according to the guideline and with the advice of the cardiologist, our next best option would be going for a medication called thrombolytics medication to dissolve the clot. And I have asked you all the questions related to this medication, and I made sure that you don't have any contraindication to this form of treatment. Once we do this, if it is successful and your chest pain gets resolved and ECG shows everything normal, then we are going to transfer you to the tertiary hospital for a proper checkup, which is going to be a coronary angiogram, where they're going to put a thin tube into your wrist or groin to reach your heart and then find out whether there is any other blocked pipes. And based on that procedure, they will decide whether you need any other treatment. If there is still some blocked arteries, they might even put a thin mesh tube like a stent to keep it open. So sometimes they might need to do that. So you will just need to say that once we do the thrombolytic treatment, if it is successful, then we are going to arrange a transfer to the tertiary hospital, and then they will make further decision. If it is not successful, then we will need to send you urgently. So you can see that was the thrombolytic therapy successful? Yes. Then arrange transfer to a center with PCI within 24 hours for angiogram and if needed, a PCI. If the thrombolytic was not successful, then it has to be transferred immediately. Are you guys nice and clear? So that's all about myocardial infarction. I hope you understand everything. Now, just to go with other cases, there is a case called angina, which is not commonly asked in exam. I always keep it in my note, so you just read it from our note. That's more than enough. This was a case like long ago, angina due to anemia. It no longer comes. I haven't seen it in exam for a while, but I would say that at least read the note once, understand the case. But these are not important for your exam. Okay? So that's going to be it for tonight. I don't think we can finish any more cluster today. So we actually increased the amount of discussion for cardiology. We have never went that much deep because sometimes I always feel that you guys already know about this because you have passed MCQ. So, but sometimes it doesn't hurt to know this basic, because with this basic you get confidence as well. So that's why I have included this basic understanding of management, so that you have that confidence in your exam. When you go there, you know everything. There is nothing they can give you that you would not know. Okay? So that's the purpose of discussing these things in that detail. You don't need that detail. Like, you don't need to know the dose of these medications, but right now you know each and everything about these cases. There is no way an examiner can fail you. Okay, that's the purpose of it. I think like the amount of case that we need to discuss for cardiology, we might need to take another session extra on cardiology as well. So we'll see how we go in our next class, because we have added a new cluster for cardiology, which is hypertension cluster, which we will discuss in our next session. There is palpitation cluster, there is a syncope cluster. So there is 3 more cluster on cardiology. So I'm sure we will not be able to discuss all of them in our next class. So we might need to include another one just to cover them up, but that's fine. So what if patient comes after 12 hours? If patient comes after 12 hours, then it is not an urgent anymore. You don't need to urgently call the catheter lab. So then normally that patient also will get everything, but within 24 hours, we will need to arrange a coronary angiogram for that patient. And based on the angiogram, we will decide what to do. So they will also get a stent or bypass surgery based on the angiogram, but it's not an urgent anymore, like the within 12 hours things. All right, so let's finish it here tonight. I think I have given you a lot of things to read, and I know that this is very extensive discussion, but trust me, with this kind of discussion, the confidence now you have for this case is much more than anyone who is preparing for this case in the same time in any other course. So that's what I want to achieve for you, making sure that when you go to the exam hall, the examiner can find the difference between you and any other candidate there. That's what I want to achieve. So hopefully throughout the course, this is how we will be doing it. As I said, that our course notes materials has got changed extensively. If any of you are here from our previous batch, you can see that like this has changed a whole lot. So the reason behind it is that I want to make sure that you are not in dark by any chance. Like you can't, like again, previous student, you didn't miss anything. We discussed the important topics. We discussed everything that is needed. Now we are discussing in more detailed way. And mainly the notes are more extensive than others. So, but why I put it in the notes that if you need to write all of this in this class, will you be able to understand what I said? The relaxed way you are learning these things, if you need to write the note, or if you need to like, let's say there is no note I have given you, or there is no recording of the class, will you be able to retain all these informations? There is no way. You will forget about this. So notes, recordings, these are going to be very important for your exam preparation, because this exam preparation takes a long time. And that's normal, because this is the last step for you to become a doctor in Australia. So take that time, understand everything, and when you start as a doctor in Australia, you will know everything, because we are giving you the guideline that Australian junior doctors follow. We are showing you the guidelines that you will learn in the hospital for the first time. So you will be already a pro when you go and start your job as junior doctor. Okay, so I'm hopeful that with this kind of knowledge, you will achieve more. So hopefully we can help you with that. Okay. For the course, you can, Dr. Simran, you can you can just give a give an email to firstaidamc 4536 at outlook.com. That's one way, or you can also directly go to our website. So I'll show you our website. So if you go to the website in here, just write firstaidamc.com.au. If you write that, this page will come up. And if you go to the extensive clinical course and go to the check info, you can actually read all the details of the course. And in here, you can also go for the registration or payment. So that is the fastest way to get access to our notes and everything, rather than even, you don't need to send us email for it because we will not do anything. We will ask you to come here anyway. So you can do it, and then after that, you can just contact us accordingly. Okay. No, there is no discount for AMC 1 students. Sorry for that. Yes, the notes will be uploaded in the portal. Any other questions about the course? Yes, so there is a 25% discount for any of our last batch students. Or also, like, normally we give 25% concession to any clinical course student who did our clinical course in the last 2 years. All right, so that's it for tonight, guys. So hopefully you are enjoying our sessions, learn all of the things that we are showing you, and I'm sure you will be pro in no time. Thanks, everyone. Have a good night. Bye.